हेलो। ठीक है।
हेलो।
Okay, so considering the burden of this prematurity and their care, and it needs to be strategized, so we celebrate World Prematurity Day event. Okay, so this is that important. So, through overview, we will see today the incidence of worldwide and in India, what is the burden of the outcome, burden of the preterm and their outcome, and physiology of the preterm transition a little bit, which is the main problem for which they need resuscitation at the labor room and some intervention in the labor room. Need of timely resuscitation in preterm via delivery room care is very, very important by that first golden hour, or even we can say first golden minute. Okay, and common pitfalls in preterm care in the labor room. So preterm birth constitute about 12% of live birth. Okay, there are different in different countries it is different, but in Southeast Asia the burden is highest, and India contributes about 30% of the burden. So because our delivery rate is quite high, and almost 30% are preterm, some are IUGR, 30% are low birth weight, from which almost your 30% are preterm. Rest are low birth weight because of different conditions in different conditions in India. And their outcome, we can see preterm related complications. Major causes are mortality, and those who survive, the morbidities in them, like cerebral palsy, deafness, blindness, all these things because of ROP, blindness also do happen. So, and other like BPD and other things. So we need to give a strategic care to them so that they can thrive and we can have an intact survival, which today our one main motto is not survival of the preterms, because now we are making them survive 26 gestational age even, and some are even giving care to 24 weeker, and Japan and Western countries, some are giving 22 weeks gestation preterm, they are giving optimal care. But India, we are mostly giving 26 weeks gestation onward. Okay, so we need to give them a good care so that they can thrive later. So, what is the concern or the physiological preterm transition that happens? Delayed long fluid clearance. In term, the clearance of fluid is very, very rapid because they are very active, and their other systems are very much mature. In preterm, again, the respiratory drive is not there, the pliable chest wall, weak respiratory muscles, and surfactant deficiency. These leads to respiratory problems, and they are more vulnerable to bradycardia due to asphyxia because the myocardium is immature, mostly contain fluid, and mitochondrial number is very, very less in the fibers, myocardial fibers. Okay, their surface area is very high as per the volume of the body, so they rapidly lose heat. So these are the few physiological things that lead to too many complications in the preterm, in the labor room itself, just after delivery. So again, the brain, which actually the major concern in a preterm baby to have in proper neurodevelopmental outcome in a preterm baby is the main motto. If they survive, in other conditions they may not survive, but if they survive, the brain may get even the brain may get affected because of different things. So the brain grows very rapidly in the later half of second trimester and third, particularly in third trimester. All sorts of the plasticity, the pruning, everything happens in that, and the oligodendrocyte, the multiple divided very rapidly, so that the volume growth is maximum in the third trimester. So if there is any problem in the physiology like hypoxia or less nutrition, if the preterm baby delivers earlier, preterm means earlier delivery, particularly let us take third trimester, so there would be a nutritional deficiency, there may be hypoxia, there may be inflammation or sepsis, isn't it, which is very common. So these lead to many these oligodendrocyte formation and differentiation into different neuronal tissues get affected. So that leads to again the germinal matrix where these oligodendrocytes, the factory, that is called the factory from where the oligodendrocytes are formed, it is highly vascular and the vascular walls is very fragile, okay, because lack of muscular intima, and so they are very fragile. Any disturbances in the physiology, blood pressure, blood volume, that may lead to your IVH, and of course sepsis and NEC, you all know. So pathogenesis of preterm brain injury in very short, I will not go into the any particular condition like already described. There are too many things, antenatal factors, and during the perinatal factors, as we discussed now, they lead to mainly cytokine release. And what happens? The pre-oligodendrocytes maturational arrest. This is the main cause. So the oligodendrocytes, which is the main functional unit of the brain, get reduced. So there occurs the complications. Plus that IVS, as we have discussed. Okay. So, why delivery care matters? Because it is the first time the baby comes out from the womb to the environment. So, the environment inside the womb is totally different when it gets exposed to too many nuisance outside. So, like critical window, 50 to 60% of preterm deaths occur within 24 hours. Okay, and they contribute very significantly to the under 5 mortality, as we have told earlier. So, early stabilization determines whether the infant transitions successfully to the extrauterine life. This is basically a transition from womb to outside. So we need to prevent all these things like hypoxia or hyperoxia, both are detrimental. And hypoglycemia, as the reserve is very less in preterm, hemodynamic instability, as I told that myocardium, those are not that strong to contract or react to the hypoxia very well, and too many invasive procedures. The lesser the gestational age, more invasive the procedures, more intervention are required to be done. So, if we improve the delivery care and send a stable baby to an ICU, the outcome will be excellent. So, the first 1 hour at labor room that determines the outcome of the many studies. They have, it has been seen that the delivery room care or early care in the delivery room determines the outcome of the preterm, both survival and morbidity. So these are different strategies. So antenatal, that is we all know magnesium sulfate and antenatal corticosteroids for neuroprotection, and antenatal corticosteroids helps in decrease in IVA, NEC, all these things. Then your delivery room preparedness, and particularly if they are requiring ventilation, then it is better to use a TPs, that we all know. And oxygen, that is to be curtailed as per the requirement. Not too much of oxygen, not less oxygen. If we is requiring, we need to give it. Okay. Then thermal protection, and to have the environmental temperature in a particular range, 23 to 26 usually, because it is conducive for the doctors giving care, also for the preterm babies. Not to maintain the labor room like 20-29 degrees. It has been seen that if you maintain the environmental temperature at that level, hyperthermia may occur. Okay, and using your radiant warmer, it is required, or at least immediate skin to skin care. But even if you are giving skin to skin care in a preterm, very preterm, then you need to monitor the temperature. That is important. Sometimes they land up in hypothermia even if with skin to skin contact. Okay, and other quality improvement things we can take for research purpose. So, concern in delivery room, that is transition of the cardiorespiratory system, particularly hypovolemia, for which what is nowadays we are doing delayed cord clamping. So the baby is getting almost 30% of the actual volume is in the placenta. So if we delay the clamping of cord, we'll talk in detail about that. then blood volume will be increased and there will be cardiovascular stability. Hypothermia, so because of larger surface area, they lose very fast and establishing the respiration. The golden minute, concept of golden minute, if required, start breathing within 1 minute. Don't delay it. Okay. So that is very, very important. Respiratory distress because the lungs is immature, drive is less, and less of surfactant. Okay. So if distress is there, then we need to manage that as early as possible. Initially, what was happening, if there is respiratory distress, then baby was first shifting to, we are shifting the baby to NICU, then there we were starting CPAP and all. Okay, no. Now delivery CPAP has shown very good strategy to improve the outcome in a preterm baby. Baby is requiring, there is baby is breathing, but it's a labored breathing. Start CPAP at delivery room. Okay, not to delay. Just transfer the baby to NICU and then start. No, you should start from the delivery room. So benefits, indirectly we have talked about this, like cord management for cardiovascular stability, hypothermia prevention, which will decrease the mortality, as we all know. Also the metabolic acidosis and LOS, how it prevents LOS, because you will need to do some interventions if hypothermia sets in. So indirectly, lesser intervention, less sepsis. Okay, and recruitment of the lung in delivery room if required, CPAP. Okay, and prevent hypovolemia, hypoglycemia, all these things if we are going for delayed cord clamping. So we all know we need to prepare the before the delivery happens. It is in our NRP itself. Team preparation, briefing, and checkup equipments. Okay. So I'm not talking about this. We all know that temperature goal. So preterm lose height rapidly. Repeatedly, I'm saying, because hypothermia we just neglect, because that if baby is hypothermic, then so many things come in minutes or in hours, so that baby survival is, particularly the calorie it burns to maintain the temperature, that would lead to hypoglycemia. Because of hypothermia, circulation will fail, acidosis will set in. So many complications. So hypothermia is not a small thing, so we will need to prevent hypothermia at the delivery room, and that may also lead to IVS and mortality. Every drops of 1 degree Celsius increases mortality by 28%. It is not a small thing, isn't it? 28%. So preterm neonates should reach NICU at the earliest. So better it need to prepare for shifting to. And the the warm chain should be maintained during the transfer. Whatever we are maintaining the temperature at delivery room, that strategy should continue till the baby reaches NICU. So admission temperature should not be less than 36.5 degrees Celsius, and at any cost, the baby temperature should not go beyond 38 degrees Celsius. Okay. So no, there should not be any cold stress. So these are thermal management bundle recommendation. So delivery room temperature, we all know, should be 26 degree or 23 to 26 degree. The warmer should be turned on in manual mode. When the baby started, you start resuscitation, you can switch over to servo control mode. Immediately after birth, less than 32 week, plastic wrap, we all know, plastic bag we receive with the cap. Okay, and baby is less than extreme preterm, we can use a thermal mattress along with this. Okay, so the maintenance of temperature happens to be better. But one thing we never do, heated and humidified air or oxygen, whatever is required. Whenever it is required, we should give heated and humidified oxygen or air, whatever we are giving. Okay, through CPAP, like if we are giving air also to maintain the pressure, it should be heated and humidified. Okay, otherwise it decreases the core body temperature very rapidly, because the manifold, the oxygen temperature is around 20 to 22 degrees Celsius. It is cold. So it baby starts losing your temperature very rapidly. Okay. So, so there were different one meta-analysis just brushing it off. The best thing is plastic wrap with heated mattress. The hypothermia is very less, but the survival and is all with plastic wrap with cap and heated and humidified air or oxygen, whatever you are giving. The survival is better if you are using heated and humidified air, okay, along with plastic wrap. So this is current recommendation 2025. So pre-term plastic bag is to be used less than 32 degrees Celsius and skin to skin care, but please monitor temperature if you are keeping a very preterm or extreme preterm in skin to skin care. Hypothermia is common in these babies in skin to skin care, but beyond 32 weeks, okay, fine. It doesn't matter. Less than 32 or extreme preterm, you need to monitor temperature, okay, and uh, exothermic mattress, as I told, particularly for extreme preterm, you can use and just follow the hypothermia prevention bundle. So next is your cardiac, that is cord management approach. It is also a part of our resuscitation. So there are different approaches like immediate cord clamping, delayed cord clamping, umbilical cord milking, and physiological based cord clamping, and cord clamping after placental separation or when it gets separated. Okay. Use of delayed cord clamping, everybody knows that is the standard of care now. Consider physiological based cord clamping where feasible. Like describe all these things. Avoid umbilical cord milking in less than 28. Okay, one study they have shown it is good for extreme preterm too, but when you segregate the subgroup analysis, it is showing clearly that less than 22 weeker IVH is quite common. Why it is common, I will tell you. So immediate cord clamping, we all know immediately after delivery 10 to 15 seconds we are cutting the cord, but we are losing the blood volume that is present in the placenta. So that is not coming to the newborn circulation. Delayed cord clamping at least 60 seconds. That NRP now recommends at least for 60 seconds. Okay, WHO says 30 to 60 seconds, but it is better to clamp the cord after 60 seconds. It decrease your IVH in preterm and require less transfusion later on. Hemodynamic stability or hypotension within 24 hours is very less if we are going for delayed cord clamping. Okay. Physiological base cord clamping, clamp after infant establishes breathing. Now it is coming up, but we are not having a strong evidence so that the baby is not requiring resuscitation, and to continue resuscitation with intact cord, evidence are not that robust, but people are doing one ABC trial that doesn't show any similar outcome. So more trials are required to follow this physiological based or clamp the cord after the respiration is established. Cord clamping after placental separation, usually separation takes 3 to 5 minutes. If you are able to do that, it's not bad. Okay, but if baby is requiring resuscitation, current evidence says no. So physiology based of cord clamping, actually the cardiac preload that is coming from both, okay, neonatal circulation and from placenta. So preload in the right heart would be better, and that will go to again left heart. So cardiac output gets better if you are delaying the cord or ventilating. If this is the physiology, if you are ventilating the baby with intact cord, physiology is saying that it is good, but evidence is not showing that. So if after cord clamping, you will see your every thing is getting lesser, the preload and afterload. Again, the afterload, what is happening? As we tie the cord, the placental circulation is very low resistance. Okay, so that benefit we are not getting. So this is in short the physiology. What happens if you do a resuscitation, delayed cord clamping, then your saturation, the target saturation we are seeing today at 1 minute is 60, then 65, it may change later on. Because the saturation is getting faster. We are achieving our target saturation, that is 85% at 5 minutes. That is our target. If the target saturation at 5 minutes is less than 85%, then mortality is quite high. It is evidence based. So our target by 5 minutes we need to achieve 85%, but with delayed cord clamping we are getting that saturation early. So if universally we will follow the delayed cord clamping, maybe that target saturation will be achieved very early, okay, earlier. So about the cord milking, what I was talking about, the extreme preterm, what happens? The pulmonary vascular resistance is high in that because surfactant production and those are not that adequate. So when we milk the blood towards from the cord, then what happens? It doesn't go to the pulmonary circulation, rather it remains in the systemic circulation and a gush of blood goes to the cerebral circulation because it is not getting diverted to pulmonary circulation. Again, the coming to the left heart, so the load would be increased, preload, so contraction will be better and more blood will, systemic hypotension will not happen. But here, because of the pulmonary hypotension or not relaxation of the pulmonary circulation, more of the blood it goes to the blood. So a rapid gush of blood going to the cerebral circulation, because that area is very fragile, you may get IBS. That is the mechanism. So we are not recommending umbilical cord milking less than 28 to 32. If baby is requiring resuscitation rapidly within 20 seconds, you can go for 3 to 4 times cord milking 20 centimeter. Okay, and these are of two type. Initially they were tying the cord and milking was done, but now you can go with intact cord. Milking can be done with intact cord. So this recommendation is for newborn less than 37 week gestation, delayed cord clamping, okay, who do not require resuscitation. They have clearly mentioned who are not requiring, then delayed. For newborn infants 20 to 36 plus 6 week gestation do not require immediate resuscitation, then deferred cord clamping, or you can go for cord milking. For newborn infants 28 or plus gestation, intact cord milking should not be performed. It is less than 28 weeks. It should not be performed. Okay. And now respiratory support, best is TPs. We all know. Even if we are having nowadays the bag and mask with PEEP valve, still TPs is better. They have shown it that still TPs is better than bag and mask. So start with non-invasive support rather than intubating the baby. And if it is required, then you should deliver CPAP at labor room rather than first shift the baby to NICU, and then only you can start. So NIPPB offers more respiratory support. It's a Cochrane meta-analysis. Everybody knows that it is better, slightly better than CPAP, but delivery room easy to deliver, that is CPAP. So at least we should start with CPAP. Then oxygen, we'll talk just after this. So for spontaneously breathing, if the infants who require respiratory support, CPAP you can start. Okay. And for spontaneously breathing preterm infant who require respiratory support immediately after birth, the effectiveness of high flow nasal cannula compared to CPAP is not well established. But in NICU condition, we all know CPAP for lesser gestation is better than your high flow, isn't it? In NICU, but a delivery room, still not much evidence is there. So next is in respiration, that is your oxygen titration. This is again very, very important. This oxygen that may lead to ROP or BPD, these are common complications with hyperoxia. So start with in a test pulse oximeter that we all know or monitor. So what is the current recommendation? 21 to 30% less than 35 weeker. But more than 35 weekers, we know it is 20% or room air, 21% of room air. Avoid high initial FiO2, which may lead to oxidative stress. Change FiO2 every 10 to 20 seconds based on rising SpO2. So we need to monitor the SpO2 and accordingly we need to tighten our FiO2 level. Okay. So avoid hyperoxia, should not go beyond 95% at any cost. On CPAP and NIPPB titrate, we keep the our saturation level in 90 to 94%. Okay. So, but during resuscitation, now the oxygen saturation term may be or more than 36, it is room air. 35 to 32, we can use 21 to 30%. And in preterm, that is 21 to 30%. And preterm less than 32, it is 30 to 100%. Now, it have learned from individual meta-analysis, individual patient meta-analysis that higher concentration resuscitation in less than 32 week, one study recently have come that it is showing survival is better in those cases. But we don't know it is 60% to 100% or 30 to 100%. That is why they have given this big range, 30% to 100%. But the best is tighter your oxygen or FiO2 as per the target SpO2. Okay. And you can see in the current recommendation, they have started SpO2 monitoring by 2 minutes, at 2 minutes, not 1 minute. Okay, so lungs protective strategy, it also depends or it decides the survival. Lungs injury should be avoided. Mostly we think it is the pressure. Now it is the volume which causes the maximum lung injury. So the tidal volume should be maintained. Volume based ventilation of course is very difficult in newborns. So volume targeted at least we can do. Volume control, that is very difficult in because the volume is very low, but volume targeted we are doing that and it is everyone is happy with that, isn't it? So minimize oxygen toxicity. So SpO2 target is to be always monitored. Optimize P, because the lungs is not opened, whatever pressure or whatever FiO2 you are giving, that will not improve the outcome. Okay, ventilation outcome. So first open the lung, then start ventilating. Prefer, and you can do that by seeing the chest expansion, or at best you can go for X-ray. But if we're clinically judging that the chest expansion is there or not, you can very well, no need of X-ray immediately. Later on, you can go for X-ray for look for over expansion or under expansion. Okay. So as I told, non-invasive is better than invasive. So always start with non-invasive, non-maintaining, then you can move on to invasive. Okay. Surfactant. Delivery room surfactant therapy is still not in practice and no evidence for that. So currently it is, but some are giving surfactant in delivery room too. If they have the facility, the asepsis, everything is to be maintained. But if it is required, as soon as possible, at least less than 2 hours, it should be given. Okay, but prophylactic surfactant currently not recommended, and best way to give surfactant is by Lisa technique. Okay, not in Insure. Insure is obsolete now, not obsolete, but you are not comfortable with Lisa, go for Insure, isn't it? So if you are confident with Lisa, then go for Lisa. That outcome is BPD is very less, very less rather in comparison to Insure. So surfactant when to give, you must have your protocol in every NICU, and we when the CPAP requirement is 8% and FiO2 requirement is 3.3 or more, we used to give. Okay. So lung protective strategy, again the gentle mechanical ventilation, surfactant at time, reduce duration of invasive ventilation. Whenever you feel like it is not required, extubate faster. This decision is to be taken faster. Every day you should know the baby is stable with this minimum setting is there. Let us wait for 24 hours. No, If baby is extubation ready, immediately do extubation. It prevents so many things. Invasive ventilation is basically is we do not want to prolong it for a day or so without any reason. Okay, if baby is ready for extubation, go for it. Okay, and uh, cardiovascular stabilization in delivery room, we have already talked. If there is, even in our resuscitation, we learned that if there is any volume loss, we need to give it as early as possible. But main is delayed cord clamping. Okay, so IVH prevention. Okay, this is very, very important. Protect the head and cerebral circulation. Head in midline, always. Don't turn it. Neck should not be twisted like this. Okay. Avoid hyperextension or flexion. Special care in NRP for preterm, it has been described. Okay. So no hyperextension or flexion. Keep the head in the midline, not twisting, not flexing, not extending it. Okay, and never do leg lifting or don't lift the hip at any point of time in a preterm. Even there is technique how to put nappy in a preterm. Okay, just nurse, what the nursing officers, they pull the lift the legs and slide the nappy. No, that's a wrong technique. So you have to place the baby laterally, then put the nappy and then make him supine. Okay. So don't lift the hip from the level that may cause IVS. We do not know that may cause IVS, and it is evidence based. Those technique usually they do IVS. Okay. So, and prevention of blood pressure fluctuation, and never give a bolus rapidly in a preterm. Okay, don't give bolus rapidly, and also this hyperoxia that may cause oxidative stress and may lead to IBS. And best way is delayed cord clamping. It gives volume, prevents the blood pressure fluctuation in the preterm in early hours, so they don't have hypotension, so less IVH, and avoid umbilical cord milking in less than 28 hours, 28 week babies. Infection. This is the most important cause of mortality in our NICU, but many a times early onset in some NICU, like my NICU, early onset is more than late onset. Isn't it? Because our delivery room is beyond control. The load of delivery is so high, it is difficult to clean after every delivery, and so UAS is more than LOS in my nursery. So we need to know how to, or we can go for a quality improvement strategy to improve the labor room hygiene in our labor rooms. Okay. So during resuscitation, all aseptic precautions should be taken, like all gadgets, including if you are using a CPAP, then circuit should be sterile, and disposable may be used, which is better in labor room to use all disposables. Those will lessen your infection rate. Last but not the least is family-centered care and involvement of the family, parents, father. Maybe in Lakshya program, it is already told that allow the father into the labor room during the delivery, or at least a female attendant. If father is not available, female companion is allowed, and everything is discussed with the family, and their support is very, very counseling and support is required to have a good faith between the doctor and the consumer, and KMC, early KMC we follow, but difficult to follow. If we don't follow immediate KMC, immediate means within 2 hours from labor room itself, KMC starts, and we take the baby in KMC position to the NICU if the baby is requiring NICU care, but up to level 2. Okay, if the baby is requiring CPAP 2, we shift the baby in KMC position, but always it is not feasible. Everywhere it is not feasible, I do agree, and more evidence may be required. So at least start KMC as early as possible. Maybe when after shifting the NICU at 2 3 hours, you can call the mother and start KMC. What is the problem? No problem. We can give CPAP, you can give IV fluid. If baby is looking like having sepsis at day 3, day 4, no issue. You can manage, except we have not tried with invasive ventilation. Otherwise, you can give continuous KMC with level 2 care nurseries. There is no issues. And rather, if mother sees everything, whatever the effort the doctors are putting in, they do not create any chaos because everything is in front of her, so they are very confident. If you explain them everything, every hour she is knowing and she is a part of the team, so we didn't have any complications or breach of trust between the patient and the doctors. And in fact the stress levels in the mother decreases, which is you can that was also proved in our study. Okay, so common pitfalls, thermoprotection, we neglect this one many a times. Suboptimal airway breathing support, CPAP is required, start at delivery room, that I can say. Poor cardiovascular management, immediately uh, see if there is cardiovascular compromise, then fluid that if there is a volumulus, start fluid. If require inotropes, then we can start as early as possible. Excessive handling is not required. Don't over flex or extend the neck or twist the neck while positioning the baby. And adequate infection prevention, of course, we talked a lot about that. Failure to implement delayed cord clamping. Sorry to say, in our hospital also, we are not able to maintain 100% delayed cord clamping wherever it is required. So some unit obstetrician, they do oblige us, rather they are obliging the baby, not us. But few, they are not still following. They are in a hurry to cut the cord. Okay. So we can talk to our obstetrician colleague to wait for clamping of the cord. Missed surfactant opportunity, delivery room. If you have your protocol, you can give, but at most asepsis is to be maintained because this is very invasive. Okay, poor communication and term communication and term condition. We don't talk to the parents, don't discuss the things. Oh, we think we are the judge and we are the advocate for the baby, so we decide ourselves. But everything should be told to the parents, and good communication is very, very important. Inadequate family-centered care, as I told. KMC, initially it was, we were initiating KMC 2 days, 3 days, even after 7 days. Suppose a baby is 30 weeker, we let it maybe 7 days, 10 days, then we are starting. No, whenever the baby you feel like baby is stable, start KMC. Okay, and we all know the benefits of KMC. It reduces everything, any mortality, morbidity, everything. So why? Because that is the best mimic of womb. That is the best mimic. That is almost like intrauterine environment. So KMC. And documentation, it should, you should have good documentation. So takeaway, we all know from NRP team and gadgets what is to be required. You should anticipate and keep them, maintain temperature aggressively to prevent hypothermia, delayed cord clamping again. This is very, very important. CPAP, if required, start from the delivery room, minimize handling and positioning, good positioning of the baby to prevent IBH, infection control, early KMC. Thank you.
मेरे को इसका आपको कैमरे के सामने जाना चाहिए क्योंकि बाकी सब लोग देखेंगे. There are more and more online, Manisha, than present here. There are more online. So please go in front of the camera. Right, you have to go.
Sure.
Please. You are the chair. Both the chairperson. The people should know about the chairperson. So let me introduce the chairperson. I think they have been introduced. They have been introduced, right?
Yes,
Yeah. So Dr. Manisha and Dr. Davinder, please I invite you here as chairpersons to have your comments.
So, good afternoon, everyone. Thank you, Dr. Pradeep, sir. It was, as expected, a very excellent and comprehensive presentation. So, just please allow me to summarize the key findings for the audience. So, like sir rightly mentioned, the management starts from the antenatal period. Apart from the antenatal care, antenatal counseling is very important. We need to inform the parents about the anticipated course. It will help us take informed decisions, as well as consider transferring the mother with the baby in utero to a center if we don't have the facility to manage such babies, if we don't have an NICU in our unit to manage such high-risk babies. So this really improves the outcomes. Second thing regarding cord clamping, so better said than done. Like sir rightly said, even in their medical college, they are not able to. So because at that time, the obstetrician is really in stress, the managing the bleeding in the mother. So what we did in our center was that we wash along with the surgeon. We took take care of the baby. We perform delayed cord clamping as much as the baby allows, while the surgeon is busy with the managing the bleeding uterus. Next, prevention of hypothermia, often a missed point. It is very important to maintain the delivery room temperature of 26 degrees Celsius. Again, better said than done, because the surgeon feels discomfortable in such a temperature. So use of additional equipments like thermal mattresses, caps, cling wraps, and a transport incubator is really beneficial in managing these babies. Apart from that, like sir said, that admission temperature should be at least 36.5 to 37.5 degrees Celsius. Very difficult to achieve, but it is a good practice to document your admission temperature while the baby comes to the NICU. Then the use of oxygen, judicious use of oxygen using blenders and humidifiers. So I don't think anybody is using humidifiers in the delivery room itself, but yes, it would be a very beneficial practice for the baby. Use of CPAP, like it is very important. I've seen fellows coming to our unit not knowing how to use TPs. They're still practicing EMBU in prestigious medical colleges also. So the pediatricians and the neonatologists need to be trained. This is our job as NNF academicians to train them in CPAP, in delivering oxygen via TPs, and sensitizing them regarding optimal use of oxygen, to use oxygen as a drug. Then, of course, like sir rightly mentioned, sepsis prevention is very important. Sepsis is the biggest killer, and the practice starts from the delivery room itself. Apart from that, KMC and early initiation of breast milk, whether breastfeeding or breast milk in any form, will be a blessing for the baby. So thank you, Pradeep sir, for this elaborate lecture. And
First of all, let me thank each one of you who is present here, and Dr. Pradeep, who has done a very comprehensive presentation. I am basically a pediatrician turned public health, so whatever clinical aspects she has already mentioned, comprehensive care at the labor room in terms of the delivery and post-delivery care of the baby. She has already mentioned the comprehensiveness. The presentation also is rich in that. Coming to the point that as the economic development is happening in the country, people are prospering. At the same time, family limitation in terms of size, family size is decreasing, and each baby who is delivered becomes precious to the family, and therefore each baby, and moreover now marriages are happening late. It is a common practice. So the preciousness of the baby delivered becomes all the more important. People are deciding, young couples are deciding to go in for only one delivery or maybe two children, child norm. So from that perspective, our role as pediatricians takes much more significant importance rather than, and therefore even training and building capacities of the obstetricians in the labor room on these basics become very, very important. Pediatricians, of course, they each one, they know most of these things that have been taught, but it becomes a reinforcement in terms of knowing and practicing the clinical aspects of proper care to the newborn baby, especially the low birth weight babies, grossly premature babies. One point probably somehow I missed listening or listening to that. Maybe this vitamin K administration probably has been missed. Less than 1500 gram baby, probably 0.5 ml to be given within first post delivery, I mean as early as possible, and 1 milligram, 1 ml, 1 milligram and 0.5 milligram. So that is to be also a part of this care. Coming to the, when I was in the state maternity and child health officer in the Directorate of Family Welfare, just for 2 minutes I'll take. At that time when I joined in the year 1998 as the MCH officer, from LNJP I directly went to that place. the Delhi in itself, we were having a infant mortality of about 46, 47 at that time, and out of which two-thirds was neonatal mortality, nearly 30, 32 was the neonatal. Today it is about the infant mortality is about 18, 17 or 18, and around 10, 12 is the new 9. So we have come in single digit. So that means the progress, whatever has happened, not only has happened because of the social development, economic development, but it is also because of the dedicated care that each one of you has been able to provide in the last so many years. I mean, people over the last 34. So coming to the point, see, in fact, this point that you have raised, Dr. Bish Surinder has raised, very important point. Building capacities of the service provider is one thing, but making things available is another thing. That means system strengthening also becomes important from the point of view of organizations like NNF. And in 2007, 2008, we did a facility survey in the state of Delhi, in the government sector as well as in the private sector. And we found that at that time there were only 600 neonatal beds available in the government sector. 600. Just imagine a city where 3 lakh plus deliveries are happening every year. Now it is 3.5 lakh deliveries happening every year. Only 600 neonatal beds. That too, when we know 30% require
10%,
at least 10% require a neonatal care, specific neonatal care facility. So from that point, then we studied the private sector. It was grossly underutilized. Whatever beds were available, they were grossly underutilized. I mean, occupancy was only 30% at that time. So 70% of the beds were in the private sector were not utilized. So we thought of an idea of why not to develop a PPP model. And this model I am asking you now as an NF to take up in the coming months. Important aspect, I have the total prototype of the model with me. We can discuss. At that time, Sundarlal Hospital in Ashok, we had agreed, everything was finalized. 10 or 12 major components of sickness in the newborn baby, premature babies, were a part of that component, this package, and it was affordable. Most important for people who did, I mean, now institutional deliveries are almost 90%, 10% are happening domiciliary still, or even out of those 90%, 20% may be happening at smaller facilities where the neonatal care doesn't exist, and therefore we need to have adequate provision of neonatal care in these hospitals. So through the PPP model, we need to develop that. I will share those details. And again, my message is obstetricians and nurses in the labor room need to be fully equipped. When we are talking of bringing up the capacities of the pediatricians and the neonatologists, we also need to keep into consideration the nurses, the sisters in charges, the OT technicians, because everything can, I mean, any situation may desire necessity for physical presence of the person who is there at the delivery must be also taken into consideration. These were the some of those points that I wanted to share, but I would like to thank you. You have given very good insight after the presentation. The summarization has been excellent, and I am complimenting you as organizers and the participants for this organization. Thank you, sir. Thank you very much.
Next, we have a talk on a specific case. So I would want Dr. Vishal to moderate this session. Dr. Vishal is a senior consultant.
Good afternoon, everyone. Thank you, Pradeep sir, for the comprehensive presentation on preterm care. So thank you, NNF, for giving us an opportunity to present the case on this platform. So as we know, hypoglycemia is a quite common problem in NICU. So we have Dr. Rajat, is a clinical fellow, to present a case of a refractory case of a hypoglycemia. So he will discuss about the management and approach of a persistent hypoglycemia. So we
If you can just hold your hand.
Yes, and you that there was mentioned about 200 beds were added subsequently in the government sector. Moini is the oldest member in terms of IEP, not the oldest in terms of age. I may be of her age.
Let's start the session.
So we have Dr. Richa Arora ma'am. She is pediatric endocrinologist as the chairperson. And Sundar sir. So Dr. Rajat is going to present the case. Over to Dr. Rajat.
Good afternoon, everyone. Today I'm going to present a case of persistent hypoglycemia. This is the description of the baby. A male newborn born at 18th 8 2025 at 8 a.m. was admitted to our neonatal unit with the complaints of prematurity and respiratory distress. The gestational age of the baby was 32 plus 4 days, and the birth weight was 3030 grams. Mode of delivery was LSCS. The baby was LGA, large for gestational age, according to the 21st century intergrowth charts. In the antenatal history, the mother was 31 years old, G2, P1, L1, A1, with a history of leaking per vaginal. No history of any drug intake like beta blockers. There was no history of any fever or rash. No history of any diabetes. And polyhydramnios was noted in the antenatal ultrasounds. Nothing significant in the family history. Delivery details: baby was born out of emergency LSCS, had difficult perinatal transition and required PPV at birth via TP resuscitator. It was given for 30 seconds. Baby was shifted to an ICU in transport incubator on CPAP. APGAR score was 6/10 on first minute. At 5 minutes it was 8/10, and on 10 minutes it was 8. The course of the baby during stay: baby was started on the CPAP support upon admission at a PEEP of 6 cm SQ and FiO2 of 30%. On admission, RBS of the baby was done, which was 31 mg per deciliter, and IV fluid was started 10% dextrose at 60 ml per kg per day as per the day of life. Sepsis skin was sent and blood culture were sent, and the baby was started on injection ampicillin and gentamicin and injection caffeine. On CPAP, FiO2 requirement increased and baby was unable to maintain saturation. Even at 40% FiO2, saturation was still 90 or less than 90. So injection tubes of surfactant was given intrathecally via laser technique at 2 hours of life. Repeat RBS after that was done, which was again 31, and total fluid rate was increased from 60 to 80 ml per kg per day. And repeat RBS done after 30 minutes was again 35. After which the concentration of the dextrose was increased. First we were giving 10% dextrose, then we increased it to 12.5% dextrose with a volume of 80 ml per kg per day. GIR at the time was 6.9 mg per kg per minute. Repeat RBS was 64 after that, and we did the sugar monitoring for every 6 hourly. We started the baby on OG feeds at 5 ml 3 hourly, and CPAP settings were tapered to PEEP of 5 and FiO2 of 21%, and later it was switched to HFNC support as the distress settled at flow of 8 liter per minute and FiO2 of 21%. In view of requiring high dextrose concentration, we had to insert UVC line and UAC, and phototherapy was started for the baby at TSB of 7.76 mg per deciliter at 25 hours of life. And injection calcium gluconate 10% was also given, as ICAL was 0.59 millimole per liter. RBS on day 3rd of life was still below the consistent readings. It was 44 mg per deciliter at a GIR of and GR was increased to 10.4 mg per kg per minute. On that day we sent the critical sample for the baby, which was serum insulin, C-peptide, TSH, growth hormone, cortisol, lactates, and ketones level. Baby passed meconium on day of life 5 after giving enema, and phototherapy was stopped at the day of life 5. Bilirubin was 9.1 mg per deciliter at that time. A TMS, tandem mass spectrometry, and a urine GCMS was sent for further evaluation. This is the list of the critical sample that we sent on third day of life. As we can see in this, the insulin of the baby is 69.3 milliunit per liter, which is higher. C-peptide is also high, 7.98 nanogram per ml. Cortisol level is within normal limit, 3.11 microgram per deciliter. Ketone bodies, beta-3 hydroxybutyrate is 0.19 millimole per liter, which was low. Growth hormone was 9.85 nanogram per milliliter. TSH was 8.34 microinternational unit per ml, and lactate was 0.8 millimole per liter. These were the list of critical samples that we sent, and RBS at that time was less than 50. Echo showed a biventricular hypertrophy, interventricular septum hypertrophy, tiny closing PDA, and moderate circumferential pericardial effusion of 5 mm with no tamponade effect. USG cranium for the baby was normal, and serum ammonia was 87. Baby was requiring a high GIR of more than 12 mg per kg per minute to maintain the normal blood sugars. So we had to start the tablet dioxide for the baby. It was started at the minimum dose of 5 mg per kg per day first. However, in between, blood sugars were below 60 mg per deciliter, and therefore the dose of the dioxide was increased from 5 to 15 mg per kg per day. We also had to start the baby on tablet hydrochlorothiazide, which is a diuretic, and it was added with at a dose of 2 mg per kg per day for the any fluid retention caused by the dioxide. And whole exome sequencing was sent. On day of life 9, injection octreotide was started because of low sugar readings. Again, it was started at 1 mg per kg. It was given IV every 6 hourly. Baby was weaned off from the HFNC support at day 13 of life. On day 14 of life, UVC was removed and PICC line was inserted, as the baby was still requiring high GIR. In view of maximum dose of diazoxide and IV octreotide, blood sugars not maintaining above 60 mg per liter, which was our target. Dose of injection octreotide was increased to maximum, which was 40 microgram per kg per day. Summary. So let's summarize the case. It was a male baby born out of a non-consanguineous marriage to a G2 P1 L1 mother at 32 plus 4 weeks of gestation. Baby was LGA. Baby was admitted in NICU with the complaints of prematurity and respiratory distress. Had hypoglycemia requiring high GIR and unresponsive to maximum dose of diazoxide and requiring maximum dose of octreotide. Critical sample indicated high insulin, low blood ketones, normal lactate, and normal ammonia. And the TMS and urine GCMS that was sent, which was also normal. What do you think could be the diagnosis for the baby? Anyone? So,
Manisha is independent one.
so this is
Or you can ask from the audience. You can ask the audience.
So insulin was 71 was low. Over to the diagnosis of 50 that is low. Yeah, so it was a hyperinsulinemia. So what type of hyperinsulinemia?
Why was antiphylline and gentamicin started on day 1?
So baby is a preterm baby, 32 weeks with a distress. So we can't differentiate between the pneumonia and the RDS. So prophylactically, we started on the ampicillin and gentamicin after sending the sepsis screen.
Another point she has written is that RBS is 2 hours of life. 31 falls between 25 to 41 in the issue.
Yeah.
Within 2 hours, which is okay. If the baby is asymptomatic, what was this?
Initially, sugar was like within the range, but later requiring the high sugar concentration to maintain the blood sugar. That's why we have increased. Yeah, in between also many sugars were done, so it was high. It was low only. That's why increased the dextrose concentration.
That starting anti fluids would lead to more hypoglycemia, persistent hypoglycemia. It would certainly not have a rebound hypoglycemia effect. And we certainly feel that there was hypoglycemia. Yes, we were little early in starting our treatment in a breakdown.
Preterm 32 weeks, that's why we started with the distress on CPAP, so we started caffeine. Yes, so any baby with distress less than 33-34 weeks requiring the respiratory support, we started on the caffeine.
So I think Dr. Sunak has written that probably is residuoblastosis. I think we'll come to that diagnosis later. And for the PET scan, PET scan could be helpful.
It was done later, it was done.
So maybe we'll come later.
Yeah.
So they are coming to these
So
diagnoses.
based on these findings, I am asking the diagnosis. So it's hyperinsulinism. So it is a
Dr. Raj Sunak has written that. Others can certainly.
yeah. So it is a case of a congenital hyperinsulinism. So we send the whole exome sequencing to find out the genetic cause for this hyperinsulinism.
So as the baby was unable to maintain any normal sugar levels even at day 4 of life, we had ruled out a transitional neonatal hypoglycemia.
Actually, go on here of one more people. If anybody is speaking, I think they should come close to that mic, not there. So maybe we wait there. Then you speak also. Yeah, fine. We'll take care. Just say we'll take care of it.
We'll take care of it. So we had ruled out transitional neonatal hypoglycemia at that time. Critical samples showed high insulin, high C-peptide, low ketones, which was suggestive of non-ketotic hyperinsulinism. Serum ammonia was normal, which also ruled out any hyperammonia, hyperinsulinism such as GLUT1 deficiency and mutation. And TMS and urine GCMS was also normal to rule out any fatty acid defects. So most likely a case of hyperinsulinism. We sent the whole exome sequencing for the baby. Despite a maximum dose of octreotide and diazoxide, sugar level were non-consistent and not maintaining above 60 mg per deciliter. Therefore, tablet sirolimus was added. On day of life 18, tablet sirolimus was added at 0.5 mg per meter square, and blood sugar were maintained after adding sirolimus. Feeds were gradually increased and IV fluids had been tapered. This is the report of PET scan done. As we can see, it indicates the focal areas of increased DOPA uptake and likely lesion in the head of the pancreas, and another similar lesion in the body of the pancreas. It is suggestive of congenital hyperinsulinism. In this case, it was a focal lesion. Baby was discharged on oral diazoxide, sirolimus, and subcutaneous octreotide. Later, sirolimus and doxycycline were tapered and stopped. Presently, the baby is only on injection octreotide, and parents were also counseled for subtotal pancreatectomy. Whole exome sequences which was sent revealed as a pathogenic variant positively described as ABCC8, location on exon 3 variant. It was homozygous zygosity with hyperinsulinemic hypoglycemia familial with autosomal recessive inheritance. So this is the approach for persistent neonatal hypoglycemia. When do we say it is a case of persistent neonatal hypoglycemia? When infant fails to maintain normal blood sugar levels despite a GIR of 12 mg per kg per minute, or when the stabilization is not achieved by 7 days of therapy. An evaluation of blood, which is critical samples, and at the time RBS is less than 50, when the plasma glucose is less than 50, it is essential for determining the etiology of hypoglycemia at that time. These are the causes for the hypoglycemia. It can either be non-ketotic or ketotic. If it is non-ketotic, it can be due to perinatal stress. It can be due to hyperinsulinemia, which can be in beta cell or GLUT1. In beta cell, there is a ABCC8 mutation, or it can be KCNJ11 mutation. There can also be fatty acid oxidation defect, and or it can be ketotic hypoglycemia, in which we look for the lactate levels. If the lactates are high, it can be organic aciduria or disorder of gluconeogenesis or glycogen disorder, glycogen storage disorder, such as type 1 von Willebrand disease. And in normal lactate, it can be hypopituitarism or isolated growth hormone deficiency or CH. It is a list of critical sample that we should send it: plasma glucose, insulin level, cortisol level, growth hormones, ketone level, beta hydroxybutyrate, free fatty acids, ammonia, thyroid hormones, and tandem mass spectrometry, and urine for GCMS also. Hypoglycemia, when we should send the, as stated, we should send the critical sample at the time plasma glucose is less than 50. Here we can see the approach if the patient has high insulin level. So it is a case of hyperinsulinism, and the patient has a low ketones and low fatty acid. So it can be due to either perinatal stress, or it can be due to genetic mutation of potassium ATPase channel defects. And other than that, it can be also GLUT1. We can differentiate between both type of gene on the basis of either WS or based on the ammonia levels. Other than that, if insulin levels are low, we look for the fatty acids and a beta hydroxybutyrate level. If the ketone levels are low, it can be fatty acid oxidation defect, whether it can be medium chain or short chain fatty acids. And if the ketone level are high, we look for the lactate level. In normal lactate, it can be panhypopituitarism, it can be isolated GH deficiency, growth hormone deficiency, or adrenal insufficiency. And in high lactate level, it can be organic aciduria, glycogen storage disorder, or disorder of gluconeogenesis. This is a diagnostic and treatment algorithm for hyperinsulinism. First of all, the first line drug for hyperinsulinism is tablet diazoxide. We give a trial of it. If the patient responds to the tablet diazoxide, we send for the comprehensive genetic testing, that is whole exome sequencing. If the patient is unresponsive, we do a PET scan in which we look for the type of lesion, whether it is focal or whether it is diffuse. For the focal lesion, the treatment is the resection of the focal lesion. And for the diffuse, we can either go for medical management or we can go for the pancreatectomy in case medical management is unresponsive. And pancreatectomy itself can cause diabetes mellitus in the patient. Take home message: hypoglycemia is one of the most common problems faced while working in a neonatal unit. It is absolutely essential to monitor sugar level as per the risk factors of the baby. Hyperinsulinism is most common cause of persistent hypoglycemia, and timely treatment for hypoglycemia leads to decreased burden of neonatal mortality and improved neurological outcome. Thank you very much.
Thank you, Rajat, ma'am. Any questions? Are there any questions?
Questions are coming from there.
Okay.
You just please. I'll just take the question. Somebody spoke about was insulin level repeated.
Sir, can I just summarize the case? This was a very tough case in the what we handled. So first of all, 69 insulin level is very high, because usually even if we see a bit of 2 or 4 insulin, it is hyperinsulinemia. Secondly, as we must have seen lot of cases, it is diazoxide responsive, as we started the low dose and gradually increase it. But in this case, it was not responding at all. Third, once we get the report of whole exome, it takes at least 3 to 4 weeks. But this is a homozygous mutation. So homozygous mutation is diazoxide non-responsive. But we came to know it about later on once we see the report. So because diazoxide acts through the potassium channels, so because in this it is potassium non-responsive, so we have to start with octreotide. This is a second line drug. And third, in this case, even though the child was initially not responding to octreotide also, then we have to shift to the third line, that's sirolimus. But starting sirolimus is tricky because it has a lot of immunosuppression. So, and response of sirolimus also takes a long time. So ultimately, finally, we were able to maintain the child on octreotide. So repeating insulin levels in such a case is not needed, because once the child is maintaining these sugar levels.
There was about whether it is backward or deciduous.
So it is a LGA baby, though, but there was no like macrosomia type. Any hemi-hypertrophy, so it could not be a background.
Biventricular hypertrophy, which I thought was more than.
Yeah, that was like, though there was no IDM history, but there was a hypertrophy, but it is not a back. We send the whole exome sequencing to, so it's come out to be ABCC8. Yeah.
And surgery also in these cases is not as easy as it is said. In fact, for this case, I inquired about a lot of setups in India. Hardly any is doing pancreatic because there are side effects of long term because of diabetes and exocrine pancreatic insufficiency. So it is not easy to do it, and we always try that the child is maintained on medical management instead of going for the surgery.
So presently, baby is doing well, and sir, any neurological deficit? Yeah.
Now it's 7 months old, and she goes on this. The child is still on octreotide. How much?
30 micrograms from infusion comes from the child last 5 months to long acting octreotide that is last year. AIMS can
Lanotride, they are long acting octreotide. Tachyphylaxis is there, but baby is responding to the octreotide. In between there was some, but baby literally tolerated the feed well. Though it can cause NEC, but there was no
So
such.
I think Dr. Shah from UK, Pratik Shah, and he is having a congenital hyperinsulinemia group. So there is a group, and he made an association of congenital hyperinsulinemia, and NS did partner in one of the webinars where I was a secretary. And yes, it is not very common, though. Yes, it's not
1 in
that common.
50,000, like the incidence of
So
it.
it is not that there are cases which in such a large country with such population, we will encounter such cases once in a while, and the case you presented shows just the same way. And this is something awareness should be there, and people need to, as Rajan rightly pointed out, a very good presentation with them. So I'm really glad that such a young child is able to present so well. So I'm thankful for this, and the approach was more important. The way you have shown the algorithm, if the resident doctor or the pediatricians are able to just do basic understanding and think towards the diagnosis, probably they would be able to take care of those things better, rather than just giving glucose, and then trying to have long lines and then sepsis and all those issues. So it would be more ventilation. I think that was something which you did.
So any baby beyond 3 days requiring not able to maintain the blood sugar more than 60, better to send the critical samples.
So I think, but since your level was just 6.5 milligram per kg per minute, when you said it was going on 12.5%, the IV concentration was 12.5%, but if you look at the milligram per kg per minute, it was still at around 6.5 or 8.
It was on the day one only, sir, but later on it goes up to more than 12.
Actually, it did go up to 12 milligram.
Yeah, yes.
And then the concentration was, sugar was?
So sugar was still like below 60 only. Only once it's come out to the 64.
The concentration of the sugar in the IV fluid.
We are centralized.
15% even here.
Beyond 15%.
Beyond 15%. Yeah.
Good. Any other?
And I think you should also come.
So what? I must thank here Fortis, Vivek, and my EBs which have found time to come over here today. Joint Secretary Dr. Shekhar and Dr. Sandeep Rawal and Susant Vivek Chaudhary sir, both all of us who could come long distance to this part of Delhi, which is again one corner of Delhi only, and we decided, क्यों शेखर हमने डिसाइड किया था ना कि हम फिजिकल मीटिंग भी करेंगे. It's good that we did not only physical, we did a hybrid mode where our brethren and fraternity members were across Delhi, and some of the members have actually talked outside Delhi also. So Dr. Kamal Arora was from Ludhiana when he was putting up his thoughts. So I'm really thankful to all those who joined online, and this is the strength of NNF Delhi, which we want to harness more and more this year when we organize National Neocon 2026 in Delhi, which will come after a gap of almost 2012 it happened, so almost a gap of for 14 years or so. So it is our duty to organize and reach out to even the distant places, and our members should be encouraged to participate wholeheartedly in all our endeavors, because अभी तो आज तो चलो फिजिकल मीटिंग थी, पर कॉन्फ्रेंस के दिन तो सबको आना पड़ेगा. कॉन्फ्रेंस के दिन तो आप ऑनलाइन नहीं कर पाएंगे, कॉन्फ्रेंस के लिए तो सभी का पार्टिसिपेशन चाहिए होगा. एंड वी रियली वांट ऑल ऑफ यू टू wholeheartedly participate, the nurses, the doctors, the pediatricians of all kinds. ठीक है, so pediatric endocrinologists are very important. We saw your role here, and we need pediatric nephrologists coming in helping us at times, putting our हम CRRT भी करा रहे हैं कई जगह पे, और कई जगह पे हम पेट्रोल डायलिसिस कर रहे हैं. Our pediatric neurologists are helping us. Our cardiologists are always so helpful in so many of our cases. So all branches of pediatrics, Shekhar, is infection is certainly is one more. All branches of IAP need to work towards a successful organization of National Con in December 17 to 20th. है ना? यही है ना डेट? 17 से 20 है ना? Yeah. Thank you, Vivek, again, and thank you all. I think you are somebody is going to have a thanks. Shekhar, you are coming in. नहीं मैंने तो सिर्फ मेंबर को कहा था, आपने एनएनएफ दिल्ली की तरफ से कहना है, बिकॉज यू आर द जॉइंट सेक्रेटरी.
I think Dr. Bisht has well summarized everything. So I will thank everybody who has joined us online and offline both. And without taking much of your time, I would like to tell you that there is an NRP day on 10th of May, and I would request more and more NRP instructor to volunteer for this cause, so that we can put up to the target, which is a 10,000 participants all over India simultaneously, which is going to be a national record. We are trying to achieve that. So anybody who is an NRP instructor, please come forward and volunteer. And those who are having their own centers on online platform also, I want to say, please come up and do NRP day, celebrate it in your center, and train as much as healthcare workers as much possible. Thank you.
Thank you so much. You want to, सर ये हमारा इन हाउस नर्सरी का प्रोडक्ट है. वो जो चले गए सर. Thank you so much. चलिए हमारा मेन नेटवर्किंग का होता है. All the work from here. चलिए मैं प्रॉमिस सुनाती हूँ. दे विशाल and विशाल रखो. Thank you. Definitely.